I'm James King, so I'm a senior lecturer in the School of Sport, Exercise and Health Sciences at Loughborough, and I guess I'm the host for this evening. This is, like I say, this is our third out of 5 in this new series of public talks, or I guess we're calling it CPD for healthcare professionals. And it's fabulous that we've got 3 new academics this evening, a couple from Loughborough University, the same school as myself, and also Dr. Jack Sargeant from over at the Leicester Diabetes Centre, or the University of Leicester. So the first talk tonight will be Dr. Emma Haycraft, who is going to talk about eating behaviours in children. Then Dr. Jack Sargeant will follow up talking about type 2 diabetes in young adults. And then Dr. Ian Taylor will finish us off tonight talking about motivation and how that links to healthcare. So just really to give a very brief introduction to Emma. So Emma's a reader in psychology here at Loughborough, and Emma is our resident expert in child development, but particularly child eating behaviour. So with no further ado, I'll pass over to Emma for her talk.
Thanks very much for that introduction, James. Thanks very much, everyone, for joining us. It's really nice to be here and to be doing this third session of the NCSEM Lifestyle Education series. And yeah, as James says, I'm going to be talking about eating behaviour in young children. And I think I sort of thought, in terms of how to get started with this, it might be good to think about why am I going to talk to you about eating behaviour in young children? And the focus of today's talk really is on young children, thinking about children who've been weaned onto solid foods. So we're going to be thinking about eating solid foods rather than milk feeding, sorry. And I think this is an area that has had a lot of attention. It gets a lot of media attention. It's certainly had a lot of research attention. I've been researching this area for almost the past 20 years. And I think when people think about kind of food and eating, there's this important message that kind of underpins this, which is about healthy eating and how this is important for all of us for our lifelong health. And in terms of healthy eating, the research evidence is really clear that the eating habits that we develop early on in childhood track with us throughout the rest of childhood and adolescence and into adulthood. So there's a lot of value, there's a lot of importance in terms of helping children to develop healthy eating habits. And by healthy eating habits, I really mean helping children eat a wide variety of foods, so a diet that includes foods from all of the food groups, as opposed to, I'm not thinking about specific healthy foods, I'm thinking about a wide range of foods. However, a particular group of foods which we know are important in our diet are fruits and vegetables, and these are essential for healthy growth and development, help to protect us against disease. And these foods are particularly common ones that not all children love immediately, but this talk is going to be focusing on what we can do to help to support children to eat a wide range of fruits and vegetables and other foods that we'd like them to have within their diets. When we think about children eating, I think lots of us might imagine scenarios like this, where children are delightedly munching on fruits, vegetables, foods that we give them. But the reality for many parents, caregivers, childcare professionals can be something that looks a little bit more like this. So food refusal, not loving foods, not loving all foods, not loving vegetables in particular, is quite a common scenario. And sometimes it can be quite extreme. We can see some quite extreme reactions. This is Sam not loving the green food that he's being offered here. And this can change mealtimes. It can make mealtimes more emotionally charged. It can make mealtimes feel more frustrating for parents or caregivers. And it can result in foods being eliminated from children's diets if parents or caregivers perceive that these reactions are suggesting that children don't like that food, so they stop offering it. But actually what we know is that food refusal or periods of fussy eating are really common in children. So this is something that most, maybe even all families encounter at some point with their children. We also know that less than 1 in 5 children in the UK are consuming the recommended 5 portions of fruit and vegetables per day. And it's actually around a third of young children who are not even consuming 1 portion of vegetables per day. So we've got issues around fussy eating, and we've also got issues around children not eating as many fruit and vegetables as we know are recommended for health. And then our environment around us has also changed in recent years. We are now living in what's been termed a more obesogenic environment. So we have become less active. Our modes of travel have become more inactive. It's much easier to get calorie dense but nutrient poor foods from places around us, often at not great cost. And we've seen rises in things like sedentary screen time behaviours, which have displaced some of the kind of traditional physical activities that children engage in. And when we take all these things together, it's no surprising that we're seeing increases in childhood obesity levels within the UK. And some of the recent data from Public Health England, from the National Child Measurement Programme, suggests that around 1 in 5 of our 4 to 5-year-olds, so our children starting school in reception, have overweight or obesity, and this increases to 1 in 3 by the time they're leaving primary school. So a third of 10 to 11-year-olds in the UK have overweight or obesity. And this is obviously a public health problem. So we're dealing with issues from multiple angles in terms of how do we help children to eat a diet which is healthy and which won't contribute to elevated weight status. I've just put this on here not because I expect you to be able to read any of the bits, any of the words on it, but really just to flag that when we're talking about obesity or overweight status, there are multiple factors at play. And all I'm talking about in today's talk is thinking about children's eating behaviours and how we can support caregivers to help children to eat a varied diet. But in particular, when we think about obesity, there is a lot more going on. But the home environment is actually really important, and it's the main place in which most children receive most of their foods. So feeding children then is an important issue. Parents and caregivers have a really important role in feeding their children, in choosing the foods they offer, and in creating mealtime experiences for their little ones. And parents and caregivers understandably have a priority of supporting their little ones to develop healthy eating habits. And in some children, that is just easy to do, and children love and will happily eat all foods. But for a significant number, actually, they will often have a reticence to try different foods. They might eat a very limited selection of foods. They might have a preference for beige foods and be less keen to eat green foods, for example. And then what we often see, understandably, is that this can cause anxiety or worry in parents and caregivers. And research evidence, some of the research that I've done and other colleagues have done that I'm not talking about today because I haven't got time, but we know that when parents are feeling worried or anxious or stressed about feeding or about aspects of parenting, this can inadvertently impact their feeding behaviours or their parenting practices, and can kind of exacerbate the situation unintentionally. So what we need to do is to help parents and caregivers to understand how they can best support their children to eat a varied diet, and to share with them evidence-based information about what works. So what can we do to help children eat a wide range of foods? And one of the most important things that we can do is to provide reassurances to parents and caregivers. And these reassurances were, lots of these are not new. This is information that's been kind of going around the academic literature for the past 20 or so years, more than that really. But it hasn't been getting out to the parents and caregivers and professionals who've asked for it. So that's the aim, that's the goal of the rest of my talk really, is to share some of these reassurances with you guys. So when we think about typically developing young children, and different rules and expectations apply to atypically developing children, but when we're thinking about typically developing young children, so they've been weaned onto solid foods, generally sort of in the preschool age range, what we know is that fussy eating or food refusal is common. Research evidence suggests that more than 50% of children will be fussy or faddy with their food at some point, and anecdotally this figure is a lot higher. And it's often the so-called healthy foods that are refused, as I mentioned earlier. So bitter foods like green vegetables, for example, which children are understandably often a little bit wary of. And I think a really important reassurance, something that we've discovered from working with families that lots of people are not aware of, is that actually these kinds of bouts of fussy eating or refusing a food that you ate on a Monday and then it's Wednesday and you've been offered it and you're thinking, the child's saying, I'm not eating that, I'm not having that. This is a typical part of children's learning and development. So in young children, actually, they go through this natural phase of learning about what they like and what they don't like and making judgments about things. And in terms of refusing foods, it's thought that this behaviour is often protective. So we tend to see increases in fussy eating or food refusal around 18 to 24 months of age. And this typically coincides with when children have become a bit more mobile, they're exploring the world independently. And it's thought that actually children being a bit more reticent about what they put in their mouths is useful to protect them from ingesting all sorts of things, some of which might not be food substances and could be harmful. So there's a reason behind why we see this behaviour, which lots of parents that we've worked with have said is really helpful to understand. The other reassurance that is really valuable to pass on is that this fussy eating, this food refusal, if children are exhibiting this, it's usually temporary and it's not usually any cause for concern. But what we do know is that caregivers' responses to food refusal or to fussy eating are really crucial in terms of shaping whether or not this behaviour is short-lived and just a short phase, or whether or not it persists and you end up with a child who grows into an adolescent, who grows into an adult who doesn't eat a lot of foods because they've been eliminated from that child's diet. So providing reassurances to help allay parent or caregiver worry or concerns can be really valuable for helping children to develop a really healthy relationship with food. And what I'm going to do now is just share a few of the evidence-based tips, strategies, things that we found from our research and that other academics working around the world have found to be effective for supporting healthy eating in children. And the first one of these is all around the idea that actually we need to repeatedly offer or expose different foods to children because children need to learn to like tastes and textures. Lots of us just assume that children will just like everything. You'll offer them a kiwi and they will happily devour it. But actually, foods have different flavours, they have different textures, they have different smells, and children themselves vary in terms of how sensitive they are to these different sensory properties. So it can take a number of offerings of a food before a child learns to like it. And what we also know is that if you want to help your child to learn to eat carrots, hiding carrots, smushing them up in another meal, in another food, putting it in a bolognese, for example, it will get the nutrients into your child, so that's a good thing, but it won't help your child to learn about the taste of carrots. And what they need is to have different opportunities over weeks, months, even years to try the taste of foods and learn to like them. And I was 27 years old before I learned to like olives. And that was an example of a food that I just had repeatedly, but not very frequently, not very often, but repeatedly over a number of years. And I had to learn to like that taste. And it's the same with children with lots of tastes and flavours. And as I say, vegetables are a food that they commonly need lots of offers or exposures to because vegetables can often taste quite bitter. The research evidence, however, tells us that most parents or caregivers won't offer a food more than 3, 4, or 5 times before they eliminate it from a child's diet. So again, we found that sharing these messages that actually it can take longer than that. Don't give up. Give your children opportunities to try these on different occasions is all really useful. And this doesn't have to just be in the home environment. Nurseries, preschools, schools can all help to provide other exposures to these foods. We also know, however, that there are challenges around costs of buying food which you think won't be eaten, and also waste. And so families need and have asked for support to navigate this. So this is about encouraging purchasing frozen food, for example. So rather than buying a whole head of broccoli, where you think a lot of it won't get eaten, actually buying frozen broccoli and just pulling out a floret or 2 for your children to try is much more efficient use of money and results in less waste. So that's another important kind of factor that's related to repeated offering, but it can take time for children to learn to like foods. Another thing which parents have found reassuring to understand, and which is a good message for us to get out there, is a phrase that was coined by Ellen Satter in the States in 1990. And it's that parent provides, child decides. And this is referring to the fact that as parents and caregivers, we have a responsibility for choosing and providing a selection of foods for our children, but that actually the ultimate responsibility for what and how much of that food they want to eat is with the child. And this is part of children's autonomy development. So this is an important aspect of all children's development. It's about them learning to make choices and to make decisions. And mealtimes, food-based choices and decisions are an important example of this. And giving children choices around foods can be really useful for helping to increase the likelihood that they will eat the foods that you want them to eat. But I don't mean kind of free range choice, what would you like for lunch? I mean, would you like peas or would you like sweet corn with your sausages? But this has been shown to be very effective for helping to get children more involved and to make them feel like they've got a bit more of a say in the food that they're eating, even from the early years. And then related to this, the evidence is really clear that actually for children to eat a varied diet, we need to make sure that the foods we want these children to be eating are available and accessible. So for example, buying a tin of pineapple is fantastic, except if your child wants some pineapple as a snack, then that tin of pineapple is not very accessible. So somebody needs to be there, probably a grown up, with a can opener or to pull on the ring pull and open that tin. So it's really important to make sure that food is both available for the child to try, but also accessible. This is about having things like pre-chopped vegetable sticks in the fridge that they can just open the fridge door and grab, as opposed to just having a whole cucumber that they perhaps won't pick up and munch on. Another important behaviour which has been shown to be really effective for supporting the development of healthy eating in children is around seeing other people eating fruits and vegetables and foods, so being good role models and eating with others. And this is because children love to copy. So they do a lot of their early learning by copying and imitating the behaviours of others. And this is an important component of social learning theory, which explains a lot of how children develop, particularly in those early years of life. So eating with other people, this photo here is taken at a local nursery in Loughborough, and it shows really nicely that actually the children are eating their snack foods together. They're watching other people. They haven't all chosen the same snacks, but they're watching other people eating different foods, which is really important for helping children to learn to understand that a food is okay. Look, so-and-so over there is eating that food. And I think this comes back to the idea that if children are not keen to eat a food, often it's because they're scared or wary or fearful of it. What might it taste like? It looks a bit odd, smells a bit odd. So this premise is quite a logical one, I guess, in that if we want children to eat foods, they need to see us eating them as well, so that they can be reassured that they're safe and not going to do them any harm. It can be really tempting to help children to eat a varied diet by pressuring or coercing or even forcing them to eat a food or some foods that perhaps the child doesn't want to. So the example I've got on the slide here is, I want you to eat all of your carrots. And this is always done with the best of intentions. It's always done with the goal of helping children to eat a little bit more of that particular food or that particular food group. But the research has shown us that actually the use of pressure or coercion or force around food can have unintended consequences. And the biggest of those is that actually it results in lower liking or intake of that food that is being that the child is being pressured to eat. So Amy Galloway and some colleagues in the US in 2006 did a really nice research study that illustrates this principle brilliantly. They had two groups of children, and the children were each given some soup to eat for lunch. One group of children were just left to their own devices to eat the soup, and the other group of children received pressure, strong encouragement to eat a little bit more, to try a bit more of the soup. And at the end of the study, the children were asked how much they liked the soup. And the children in the pressure group rated the soup as less liked. So they liked the soup a lot less than the children who had just been left to their own devices to eat the soup. So while it can be effective, it can mean that, you know, the child eats a few more mouthfuls of that carrot. Actually, if your goal is to help your child learn to love carrots, this is unlikely to be the tactic to do it. Repeated exposure, modelling, gentle encouragement, praise are all more effective in the longer term at helping children to learn to like foods. Another reason why controlling behaviours like pressure or coercion or force can be problematic is because they can disrupt children's internal regulation around fullness. And this is important when we think about levels of overweight and obesity. Children are born able to know when they're hungry and when they're full. They will signal when they want food, and they will stop eating when they are full. And the more that they receive external pressures to eat beyond their own fullness cues, the more they stop listening to their internal messages around hunger and fullness. So inadvertently, we can be teaching children to ignore their own cues where their stomach is telling their brain that they're full, and they can overeat more than they actually need to. And part of the reason that this might be occurring more commonly of late is to do with portion sizes. Portion sizes for all of us have increased in recent years, but children's portion sizes are often far bigger than they need. And many savvy children will start with the foods that they like the most and stop eating when they're full. And then this often means that they've left their least preferred food, which perhaps is the vegetables, or it might be the kind of source of protein, whatever it is that they're least keen on. So in order to avoid pressuring children to eat the carrots that they've not touched any of, actually offering children smaller portions of all of the foods that you want the child to eat, and then seconds if they've finished and they're still hungry, is a better way to approach this, rather than potentially giving them too much food and then having to coerce them to eat some vegetables. Another important message that parents have found really valuable to learn about is this notion that we need to remember food is a fuel. It's there to give us energy. It's there to help us exist and stay alive. And it's not a tool. Food can be really powerful in terms of helping children, helping us to get children to do certain things. But we need to make sure that we avoid using food either as a reward for a behaviour or in response to emotions. So a common scenario is you've got a child who hasn't eaten their carrots, and you say, oh, if you eat those carrots, or if you eat 3 of those carrots, you can have some ice cream for pudding. And it works. It's often quite effective. The child will probably eat the carrots and then they'll have the ice cream. But what it does is it makes that ice cream, which is already quite a preferred, favoured food for most children, makes that even more desirable. And it makes the carrots less desirable. Children will be thinking, why am I being bribed to eat these carrots? They must be really grim if I'm having to be coerced to eat them with ice cream. So we need to avoid using one food as a reward for another. And it can also be very effective and tempting to use a food in response to emotional states in children. So if a child's fallen over and grazed their knee and they're crying, you know, oh, come on, let's go and get some chocolate buttons and you'll feel better. What all of these things do is they teach our children, again, to eat in response to external rather than internal cues. If we're using food to respond to children's emotions, it can teach children to use food rather than other coping strategies to respond to their emotional states. And if we're using food for reasons aside from kind of fuel and enjoyment, then actually, again, this can be a contributory factor to overweight and obesity. But we do acknowledge that children often need a little bit of gentle encouragement to try new foods. And the research here is quite clear that if we're using non-food rewards, things like stickers or star charts, these can be really effective for encouraging children to have a taste of a disliked food or even a novel food that they've not tried before. And this has been found by some researchers at UCL and also by Claire Holly, one of my former PhD students, who did a nice study where parents offered children a taste of a food that it was a vegetable actually that the children didn't like once a day for 2 weeks. And if they tried it, they got a sticker. And at the end of the 2 weeks, the children's liking of the previously disliked vegetable had significantly increased. So rather than using food as a reward, we can use non-food rewards like stickers. And then it can also be helpful to give children opportunities to encounter or be exposed to foods away from meal times. So having fun with food in other settings can also help children to become more familiar with and less wary or fearful of these foods. So this can involve playing with foods, can involve potato printing, for example, or it can involve games that involve foods within them. So this could be a kind of digital game. We developed Vegetable Maths Masters, which is all about exposing children to vegetables and getting them to practice their maths. But other games like going shopping or kind of creating meals can be really helpful. There's lots of games out there on the market, as can growing your own food. You don't need a garden or an allotment for this. Even growing cress on a windowsill can help to get children excited and learn about kind of where our food comes from. There's some really nice research that's come out of the University of Reading, which shows that reading stories about foods can help children to be more familiar with them, and reading the stories about foods has been associated with greater likelihood that the children will eat the foods afterwards. And cooking involving children in mealtime preparation has also been shown to be really effective for helping children to be familiar with and to eat a wide variety of foods. So when we put all of these things together, the use of what we call in the research literature positive food parenting behaviours, this can all help children to eat a variety of foods. So we're talking about repeatedly exposing or offering foods to children, being a good role model and letting children see you eating these foods, not forcing or pressuring children to try them or using foods as a reward, but possibly using stickers or star charts to encourage children to give something a taste. Good old praise can go a long way in terms of helping children to feel confident to try foods, and then having some fun with foods, as I say, particularly away from meal times. All of these things together can help to increase children's familiarity with foods and decrease their fear or their concern that something looks a bit weird or it smells a bit odd. And ultimately, this can result in greater acceptance and liking of a wide variety of foods, which for many families is the overarching goal. So families told us about 10 years ago, decades ago, that they needed support. So there's lots of information out there about milk feeding and about how you wean your children onto solid foods. But then there was a lack of support about what you did when you were trying to encourage your children to eat a varied diet, and how you dealt with fussy eating and food refusal. So parents, caregivers, professionals, childcare professionals, health professionals all told us that they wanted support and advice to feed their children positively and responsively. So as a result of that, with my colleagues Gemma Whitcomb and Claire Farrow, we created the Child Feeding Guide. Excuse me. And the Child Feeding Guide is a website, a web app, and it's online training courses for health and childcare professionals. And the goal of the Child Feeding Guide is to share effective, credible support and information with these users. It's shared by the NHS, so it's part of the information service for parents' emails that the NHS sends out, and it's also been widely shared by a variety of NHS trusts, by health professionals, dietitians, nutritionists. A whole host of people have helped to disseminate this resource, because users tell us that it's filling a gap in terms of this support that people want. And to date, it's had more than 100,000 users, and the feedback on it is really positive in terms of providing some of these reassurances that I've talked about in this evening's talk. And we've evaluated the Child Feeding Guide to see if it's doing what we hoped it would do. And we asked a group of parents, they were actually all mums, to use the Child Feeding Guide as much as they wanted over 4 weeks. And what we found was that after 4 weeks, they reported improvements in terms of their child feeding behaviours. So particularly, they used less pressure, less control with their child around feeding. But also we saw significant reductions in general levels of maternal anxiety as a result of reading and engaging with the reassurances in the Child Feeding Guide. So that's really positive. Not only is it changing caregivers' behaviours, but it's also helping them to feel less anxious and more confident about feeding their children. So the overarching goal then, and what the Child Feeding Guide aims to do, and what I hope I've done in this brief talk, is to enhance our understanding about how we can feed children. And by doing this, I hope that we can help children to move away from feeling like this about foods to feeling a little bit more excited about eating a wide variety of different food types. Thank you very much for listening. If you want to learn more about the Child Feeding Guide, the web address is there, and these are the Twitter handles.
Brilliant. Thanks very much for a really interesting talk there, Emma. Certainly taking away some tips for myself, but really some nice practical guidelines as well there, which is the whole purpose of this particular series of talks. There are no questions in the chat at the minute, so if anybody does have any questions, please do use the chat box. If you think of anything sort of going forwards, we'll answer those at the end. But before we pass over, Emma, I might just ask a question in the sense of, from a research perspective, what are like the real hot topics at the moment in your area? Like, are there any sort of contentious areas that people are trying to sort of sort out at the moment?
Oh, that's a good question, James. I like it. We've just got some funding, so therefore I assume it must be a bit of a hot topic, to actually develop some really tailored support around how caregivers can help children to eat vegetables. So the child feeding guide is general, how can we eat a healthy diet? But vegetables are such a tricky one. We've got some support for that. And then also some support around what to do when you've got children at the other end of the spectrum. So children who are always hungry, always saying, can I have that? Can I eat that? And they're happy to eat avocados, broccoli, chocolate, toast, all of these things. So again, we've got some work that's going to be starting in November to understand how we can kind of support caregivers to deal with that other end of the challenge, because it's quite a common one for lots of different people.
Really interesting. I might come and chat to you about that, Emma, because that sounds just like my 2-year-old.
Feel free, James, you know where I am.
We have just had one question from Chris. Can you see the chat box, Emma?
Yes. I can. Okay, when I say no force during the child's meal, to what extent should you encourage eating the foods? Okay, so this is a great question, Chris. It's a really delicate balancing act, and I think one person's encouragement could actually be another person's pressure or force. But the idea is gentle. Why don't you have a taste of? Would you like to try? Rather than you must eat, or you're not leaving the table until you have had 3 more mouthfuls of. So I think kind of gentle encouragement is the way to go, acknowledging that the research evidence is clear that children can need support to learn to become confident to eat these foods. If they're feeling fearful about them, then actually just putting carrots on the plate isn't in many cases enough. They need to see others eating them, and they need to have some praise and some encouragement. And in terms of how many times you should provide encouragement before it becomes forceful, I think there's probably, I'm not sure there's a number, because again it depends on the way in which it's being framed, but a few times is probably enough. If it's incessant, try this, why don't you, have you thought about, would you like to, then actually you've changed the emotional context of the meal, and that can cause all sorts of other issues.
Brilliant. And then there's just, perhaps we take one final question from Christine that's in the chat, Emma, then we'll move on in the interest of time.
Yes, sorry, just reading. It's a long question. Work with families diagnosed with autism. Yes, so there is, so we don't have, with the child feeding guide, we don't have any specific training or resources to support individuals with an ASD diagnosis, but some of my colleagues at De Montfort have developed, I think it's called a sensory toolkit, which is specifically to try to target this gap in the kind of support literature around the fact that actually individuals with ASD have different sensory challenges and need support in a slightly different way. I'm not sure if it's widely available yet, but if you want to drop me an email or let me have your details, I can put you in touch with the person who's created it so that they can share that information.
Brilliant. Right, we'll leave it there for time being, everybody. Thanks again, Emma, for that. And Jack, are you ready to go?
Yeah, camera back on. There we go.
So Jack is a research associate who's based at the University of Leicester, but works at the Leicester General Hospital in the Diabetes Centre. And the reason why I asked Jack to give this talk is because Jack was responsible for putting together a programme grant for the National Institute of Health Research around type 2 diabetes in young adults. So Jack is very, very knowledgeable in this area, and hopefully he can share some great insights. I'll hand over, Jack.
Thanks, James. What a build-up. But yeah, thank you for inviting me to talk, and thanks, Emma, for a great talk before. It's really interesting, actually. Something that I know very little about. So, like James said, I'm going to talk tonight about type 2 diabetes in young adults, and we'll go on to sort of explain what we mean by that term in the next few slides. So if we start to begin with just with type 2 diabetes generally, and we won't dwell on that for too long, but as I'm sure most, if not all of you are aware, type 2 diabetes is a chronic progressive condition characterized by high blood sugar and accounts for approximately 90% of diabetes cases worldwide. So it's primarily a result of a reduction in insulin effectiveness or insulin resistance, at least when diagnosed. So unlike type 1 diabetes, when you're diagnosed with type 2 diabetes, the pancreas is still producing insulin very often, but the body's response to it is impaired. Obviously, over time, people with type 2 can then become insulin dependent and obviously go on insulin therapy. So type 2 diabetes affects approximately 460 million people worldwide. Now, these figures that I've got on the screen are for all cases of type 2 diabetes, so obviously 90% of them being type 2. And as you can see, these are data from the International Diabetes Federation Atlas that these numbers are projected to increase. And I've put numbers up there for worldwide, but also for Europe. So type 2 diabetes commonly coexists with obesity and physical inactivity, as well as other comorbidities, those directly related to obesity and physical inactivity and cardiometabolic health, but also other comorbidities. And again, we'll come on to talk about that in a few slides' time. So it substantially increases risk of microvascular and macrovascular complications, so neuropathy, retinopathy, heart attacks and stroke, as well as others. And diabetes is within the top 10 causes of death globally. That's diabetes itself and also its complications, with an estimated 4 million deaths in 2019. So there's obviously loads of resources around diabetes and particularly type 2 diabetes, but I do think that if you want to know a little bit more, then the International or IDF Diabetes Atlas that they renew quite relatively frequently is a really nice resource and covers lots of different topics. So moving on to early onset type 2 more specifically. So obviously these are very generic statements, but type 2 was traditionally considered only really a condition of mid to late adulthood. But what we have seen over recent decades is a concerning rise in the prevalence of type 2 diabetes in younger people. And that includes children and adolescents, which obviously gets a lot of attention, but also younger adults who often can be a little bit forgotten. So clearly there's a lot of attention in children and people under the age of 18, but those early adults between 18 and 40 often get a little bit forgotten about. So in the UK, type 2 diabetes diagnoses under the age of 40 have more than doubled since the 90s. And it's estimated now that early onset type 2, so under the age of 40 or 50, depending how you define it, represents about 15 to 20% of cases worldwide. So clearly the message here isn't that younger cases of diabetes have overtaken type 2 in older people, but the relative proportion of people being diagnosed younger is increasing. And there's the figure here with world figures and also regions across the globe. So early onset type 2 is considered an aggressive form of type 2 diabetes with more accelerated deterioration of beta cell function and also faster development and worsening of insulin resistance, as well as various other mechanisms that contribute to its development and progression. Now, severe impact for people, even compared to type 1 diabetes, depending on the study and the metrics that you use. So these complications include premature atherosclerotic changes and increased risk of cardiorenal events, but importantly occurring at an earlier age due to that earlier age of diagnosis. And the rates of these events are greater compared to people diagnosed later in life. You also see higher risk of cardiovascular and non-cardiovascular mortality, a greater number of life years lost or shorter life expectancy. And I'll show you some figures now, actually. So this was quite a nice study that was published. I haven't put the date on this. This is testing me, but I think it's about 2018, so 5 or so years ago. Using data from Sweden, they have a large diabetes registry, which is a really nice research resource. And this data was collected between 1998 and 2012, containing over 300,000 people with diabetes compared to over 1.5 million people without. And on average, these people were followed up for approximately 6 years. And what you can see, just to work through these figures, is this indicates the risk of various events happening. And so the further to the right, the greater risk of this event occurring compared to somebody without diabetes. This is also broken down by age group. So you can see here for heart disease and cardiovascular disease, the chances of having a diagnosis of these two conditions within the follow-up of that study, i.e. within the average 6 years that these people were followed for, was substantially greater in people at a younger age compared to at a late when they were diagnosed later in life. And I know this is being recorded, but if this really doesn't make sense, then please do shout and I can go through it again. I don't mind stopping and going back. What we actually see is not just diagnoses of those comorbidities, but also for acute events such as heart attack and stroke. We see a very similar pattern where people who are diagnosed at a younger age have greater risk of these events occurring compared to their similarly aged people without diabetes, and much greater than people. The difference between diabetes and not having diabetes is much greater at a younger age than it is later in life. And we see the same for death, either by all-cause mortality or cardiovascular mortality. And actually a nice little quirk that you often see in this data is that a diagnosis later in life can actually be protective, because then you're actually being cared for and receiving various ways to try and prevent dying. And actually it's the people who aren't diagnosed, who possibly have underlying disease, that actually have a higher risk of these. And again, a similar message, but displayed in a different way. We see here that the years of life loss, so the difference in life expectancy for people with diabetes compared to without diabetes, is much greater when you get diabetes younger compared to later in life. So once you get to late 70s, 80s, and then 90s, actually being diagnosed with diabetes at that stage or type 2 diabetes doesn't have much impact on your life expectancy. But if you look at people earlier in life, and if we say take the 21 to 30-year-olds, it's a good 7 or 8 years of life lower, life expectancy lower compared to people without diabetes. So what's causing this? Well, we often see that these people with early onset adult diabetes have an extreme risk phenotype. And this includes traditional cardiometabolic risk factors such as higher BMI, poor glycemic control, more adverse lipid profile, more ectopic fat, lower levels of physical activity, compared to people obviously without diabetes at that age, but also compared to people being diagnosed later in life. So I guess the message being that obviously the body is relatively resistant to developing type 2 diabetes, so to develop it at such a younger age, very often the risk factors that you've got are exaggerated compared to when people are diagnosed later in life. And actually as well, we see evidence of early changes in cardiac structure and function, and the reason I bring that one up in particular is to show you a bit of data that we collected in Leicester, where we had 3 groups of people in one of our research studies. We had lean controls, we had controls with obesity but without diabetes, And then we had people with obesity and diabetes, but these were all under the age of 40. And what we saw was that diastolic function and also cardiac structure with left ventricular mass was worse in the people with type 2 diabetes, even compared to their sort of weight and age matched controls who didn't have diabetes. So it's not the obesity per se that's driving this, but something seems to be really occurring with that development of type 2 diabetes. So other factors that we often see in these younger adults is more prevalent multimorbidity compared to people, or the rates of multimorbidity. There's very few studies directly comparing these, but the rates of multimorbidity in people diagnosed with early onset type 2 is very high. And again, this includes what we call concordant or sort of related obesity associated conditions like hypertension, dyslipidemia, fatty liver disease, and cardiovascular disease. But also discordant conditions or ones that you might not traditionally consider straight away. And we also see, particularly compared to older adults with type 2 diabetes, we see higher rates of depression, anxiety, low self-efficacy, and diabetes-related distress. Developing early onset type 2 is also associated with being from a minority ethnic group. Now we know that these groups and these communities and these ethnicities have a higher risk of type 2 diabetes, but this is even more pronounced in early onset type 2 diabetes. They very often have lower socioeconomic status and higher rates of unemployment. We see a higher prevalence of learning difficulties, particularly in our local data. Other aspects related to social care, things like being single parents. And very often we see poorer self-care practices. And this probably isn't the best place for this bullet point actually, but all of these sort of extreme risk factors that I've talked about are also combined with the fact that people are likely to live with type 2 diabetes for longer, having been diagnosed with it at an earlier age. So just to provide a little bit of data about some of these, what I mentioned, the poorer self-care practices. So this is a study performed in Australia by some colleagues that we work with relatively regularly. And the reason that this table is quite nice because you can also see these higher rates of depressive symptoms and moderate severe depression in the left-hand column, which is people under the age of 40 with type 2 diabetes compared to older adults with type 2 diabetes, but also interestingly compared to age-matched people with type 1 diabetes. Don't quite see the same for anxiety in this study, but our researchers like to rely on our statistics a lot, but if you do eyeball the data in terms of the average numbers, there's a bit of a trend towards these higher anxiety symptoms as well. And working towards the bottom of the table, we also see scores related to healthy diet and physical activity are also lower in these adults with early onset type 2 compared to the older type 2 diabetes patients and the type 1 diabetes. And narrowing in on a few sort of specific behaviours, this is another analysis from Australia using the Australian Diabetes Audit. We see that the odds ratio, so the chances of people reporting difficulty in following a recommended diet, not checking their glucose as they're recommended to by their healthcare professionals, and also forgetting to take their medications entirely, the chances of those being reported are much higher in people under the age of 64 compared to people over the age of 64. This isn't obviously quite as younger age groups we were talking before, but there were methodological reasons why they chose that cut point. So what do people with early onset type 2 think? We've done quite a lot of work now trying to talk to people with this condition. There's clearly not loads of them around compared to older people with type 2, but we've got a really great sort of public engagement program and great people helping us to reach out to these patients over in Leicester and beginning to conduct more and more work with them. So they often report that other priorities in lives mean that their self-care and their sort of diabetes management generally falls down the priority list, and examples can include childcare, early careers, and also social lives, early families and relationships, friendships, and just other life events that get in the way, including going out on a Saturday night. But also they report that current healthcare is not always compatible with their complex needs, particularly in around the timing and format of appointments. And I often use the example that if you do have a single parent who has a young child in school, then a 3 o'clock appointment at the hospital might be something that they just, or you can understand and see why DNA rates are high if people can't make those appointments due to things occurring in their lives. They also report quite an interesting one, that it's very understandable why this happens, but focus within their appointments can often be simply on blood sugars and body weight. But if these people are do have other conditions going on and mental issues around their mental well-being or their social care, then actually their blood sugar and their body weight is the last thing on their mind. And actually it might be that addressing some of those other things are more important to them, which will allow us to move on to blood glucose regulation and body weight in time. So of course these are very broad statements and on an individual basis change and vary greatly, but it is a recurring theme that's quite interesting to hear when we speak to these people. Other factors, I guess, to consider or that we hear is a lot around stigma, and this occurs from colleagues and friends and peers who probably don't have many, if any, other friends with type 2 diabetes, and so often don't know how to react to it, talk about it, and that can really impact on the person who has diabetes. But also older individuals, and this has come out on more than one occasion of people going to often secondary care diabetes appointments and other people in the waiting room saying, oh wow, you're the youngest person here, which may be quite innocent, but may also have quite great impact on these people, and is clearly something that people remember because it comes up in our groups. Another sort of factor to consider really that comes out in terms of the differences in lives between younger people and older people is often geographical relocation. And these younger adults may be moving around locally, but also around the country if they're going off to university or finishing university and trying to find a job or meeting a partner and various things like that. Now, I think there is an issue around miss and prolonged diagnoses because they are rarer. I think I'm not a clinician, and so I'm just going on what I've discussed with the members of the team who do sit down in clinic, but they do get people who arrive in secondary care having been told that they've had type 1 diabetes and get into secondary care and they don't. And I don't think that's I think that's very understandable, but something that does impact on the patient themselves. Whether we should consider choice of therapies and whether the therapies used for their diabetes management may differ. Clearly, diabetes glucose lowering therapies such as the GLP-1 receptor agonists, so your liraglutide and semaglutide, and your other classes of drugs such as the SGLT2 inhibitors, which was a mouthful to get out, are really becoming more and more prominent in diabetes management generally. But these are associated with reductions in rates of cardio and renal events. So whether we want to be prioritizing those in younger people who are at higher risk of this over their lifetime is something to consider. Use of technology around appointments and self-management and other aspects of diabetes care is clearly important and something to consider as well, quite again across the board, but maybe particularly in younger adults. And I think as well a lack of peer support, and I mentioned it a little bit above about these younger people who might be the only people in their close and wider friendship group to be trying to manage type 2 diabetes at a younger age. And so I think finding methods to increase peer support across the country really and beyond, and this is where technology may come in, is really important. So moving a little bit on to a bit of research, and I'm probably very self-indulgent to include something that I led on, but it's also a little bit worrying that these patients, these younger adults, are severely underrepresented in the big clinical trials that underpin guidelines. So we reviewed 90 of the big trials, which recruited a total of just shy of 270,000 participants. And this included the large, what we call cardio-renal outcome trials, looking at the impact of various therapies on cardiovascular events like heart attack, stroke, and renal events like advanced kidney disease, but also death. But we also looked at the phase 3 drug trials that underpin licensing for therapies, and then the large trials of self-management and lifestyle interventions. And actually, the average age of these participants was 63. Less than 5% were under the age of 40, and many excluded adults under 50 or even 60 altogether. And so these large cardio-renal outcome trials, which are really essential in a drug program achieving licensing, less than 1% of the participants taking part of in those studies were estimated to be under the age of 40. And it's for that reason, as well as lots of other review of evidence, that it really has been highlighted as a national and international priority. And so within the NHS Research Needs Assessment from a few years back, I think 2019 possibly, interventions in under 40s with type 2 diabetes was highlighted specifically. And then within NICE research recommendations, there's a call for the need to examine differences in diabetes management strategies by age. And then lastly, there's a recent Global Lancet Commission, which came out last year, which highlighted young onset diabetes as a priority and had a whole section on it. So that is a large document and a large dense document, but it is quite nice. It contains a lot of information and does have a whole section related to young onset type 2. And that's not just in the UK, that's globally. So just to finish off, talking about a little bit of work that we've done or are doing at the moment and will be doing in coming forward in Leicester, is this NIHR programme grant that James mentioned at the start, which is a programme called M3. It's a 5-year programme. We will receive £2.5 million to do it. And the aim of the programme as a whole is to develop and test the effectiveness and cost effectiveness of an innovative multifactorial management intervention to address multimorbidity in early onset type 2. Now, that's a mouthful. That's a very typical research application title. But what that means we want to do really is speak to these patients, speak to healthcare professionals, look at the literature, and try and come up with a new care pathway that is tailored to their needs. And that's not to say that it has to be radical and completely reinvent the wheel, but just something that really addresses the important factors that matter to them in order to try and improve their care. And so this will include various work over the 5 years, including review of existing evidence and analyses of real-world data. There's going to be a qualitative study with patients and with healthcare professionals. We'll design the intervention itself and then an accompanying healthcare provider training package. And then lastly, we'll test it in a large clinical trial in probably at least 4 different sites across the country. All throughout, there'll be lots of public involvement to guide and make sure that what we're doing is patient focused. And we will need to do some health economics to check that it not only works, but is cost effective, or assess whether it's cost effective as well. Oh, there you go. So I'm not sure how well this figure will work on your screens. I'm afraid it's a bit tiny on mine, but this is just an initial idea of what we think will be the key features of this intervention. And these ideas will be shared with patients and healthcare providers, and they'll tell us if we're wrong, but we're pretty confident that these will be key factors. So we think we want a hybrid approach of both digital and face-to-face contact, meaning that you get 12 hours of contact time, but importantly, it's high quality contact time across the year, and definitely with a minimum of quarterly review. And so, again, it could be personalized, and high quality could be digital. For, I think, the pandemic, certainly in our place, I think a lot of the clinicians have really, after a bit of a baptism of fire, a lot of them have really seen the benefits and grown into some of the digital ways that that they're providing their care for their patients, including video calls and various other strategies. So I think not for everybody, but digital methods of clinical care delivery can work for some individuals and actually be of a higher quality than face-to-face contact time, if actually it's more convenient and works for that person. We're quite keen that the care is coordinated by a designated person within the team. So it will clearly be delivered by a multidisciplinary team, but that sort of single point of contact, a diabetes specialist nurse or somebody similar who really has a caseload of patients and ensures that continuity of care for a given person. We think, well, we're convinced that this will need to be underpinned by the use of technology, and importantly, will target holistic risk factors. So not just that glucose and weight, which is clearly important, but also social care and mental well-being and other factors as well. And as I possibly hinted at earlier, we're certainly of the opinion that promoting some of these newer therapies that are shown to support weight loss and reduce cardiovascular and renal events could be really important and helpful in these younger individuals. So watch this space really over the next months and years really, and please do get in touch if you would like any more information. This could be about just generally about the presentation tonight, but also if you are interested in getting involved in this work or know someone who might. As I mentioned, we're looking to do work in people with early onset type 2, but also healthcare providers from primary care, secondary care, social care, and at various levels. So yeah, please do get in touch if you're interested. So there we go. That actually went on longer than I thought. I was going to be scrambling around for time, but thanks for your attention, and I can take any questions.
Thanks, Jack. Really interesting talk there. I know teaching this sort of content, particularly just general type 2 diabetes to my students, there's been quite a few stories in the media over the last few years about increasing numbers of individuals with diabetes. Is my understanding right then, Jack, if I just sense check against you now as almost the first question? So basically what we're seeing is, I guess, childhood obesity, and obviously with that ectopic fat, it seems to be the same pathway to type 2 diabetes in younger individuals. It's just that for whatever reason, these individuals are starting earlier on. So is there perhaps some sort of genetic susceptibility? Does this, I guess, do we see these individuals who are developing diabetes in young adulthood or even as children? Do they have parents that have type 2 diabetes?
Yeah, so absolutely. So there are another risk factor. You're absolutely right. Is family history. Absolutely. So I don't think we've got quite as far as identifying certain genetic factors themselves, but I think clearly you can infer from that really strong link to family history. I think you're right about it's not a coincidence. This is going hand in hand with some of the similar factors that Emma mentioned before, and reductions in physical activity right from an early age, and the obesogenic environment that we're seeing. Higher rates of obesity are clearly playing a factor, as well as those sort of non-traditional factors that these are associations with some of the mental well-being conditions that I taught. So whether higher rates of depression and anxiety are contributing to early diagnosis as much as early diagnosis is contributing to higher rates of depression and anxiety themselves. So we're still waiting to tease out really the direction of that relationship, and I suspect actually it's possibly could be each way in different individuals.
I can remember some stories on the BBC News, and I think they were basically suggesting that the prevalence is a lot greater in the South Asian community, suggesting that, well, it's either lifestyle differences or or more likely a genetic element, particularly around, body fat storage?
Absolutely, yeah, absolutely that. So we know the risk of type 2 is increased in particularly South Asian people anyway, but that sort of susceptibility and proportion is even greater in the younger age groups.
All right, so no questions in the chat at the minute, but if you do have any questions, please feel free to pop them in the chat. In the interest of time, though, let's thank Jack again and move on to Dr. Taylor. You there, Ian?
Yep, bear with me.
Brilliant. So Ian is a psychologist within our school, and he is our expert on all things motivation. So I will pass over to you, Ian, because time is moving quickly on.
Splendid. I'm just, bear with me. Okay, thanks. Thanks, everyone, for eating into your own evenings for this talk. Yeah, I'm going to talk about motivation. And generally speaking, motivation, probably the examples given will be about getting people to do more physical activity, more exercise, or to maybe to eat in a healthier diet. As well as you as healthcare professionals, probably the context, most obvious context is you trying to get other people, patients, clients, etc., to be more motivated. But I think it also helps to think about using these principles to get yourself motivated. So try and think of an example where you sort of, you might want to do more exercise, but never quite get around to it. So hopefully that will help yourself as well as your patients and clients as well. So I'm going to start off with the sort of misunderstanding, the common misunderstandings about motivation. And the broad definition of motivation is it's the psychological forces or the brain processes, if you're more cognitively minded, that drive behavior. And that's important to clarify because people often infer motivation from behavior itself. But actually behavior is not a good indicator of motivation. So I'll give you an example of, there are lots of people who go to the gym, but some of them could be going to the gym because they're obsessed about their weight and looking good, whereas other people go to the gym for the motivation because they love it and it's really fun and so forth. Equally, people listening to this might be motivated because they're really enthused about diabetes and child feeding and motivation and stuff. Whereas the others are probably thinking, I'll just get a couple of CBD points and so forth. So actually sort of attendance and behavior are not great indicators of motivation. Somebody might be doing exercise or eating a healthy diet, but it gives us no indication of how resilient and how robust those underlying motives and behaviors are. And the second common myth that you will see is quite often people will say, I'm motivated, but so I'm motivated to eat well, but Jackie from accounts keeps bringing cakes into the office every day. Or I'm motivated to exercise, but I don't have the time. Or I'm motivated to exercise, but the gym's not nearby, and so forth. And so people think that motivation is fine, and there's some sort of usually external factor that's the problem. But actually, what the problem there is it's the wrong type of motivation. As the definition at the top says, it's the processes that drive behavior. It's not the processes that drive intention or a goal or a wish, okay? So if someone's saying I'm motivated, then it usually means that their motivation, they've chosen the wrong motivational system. Motivation is not just one single construct that varies in magnitude. Motivation is a range of complex sort of intrapersonal psychological systems. And if intention doesn't transfer to behavior, then it's the wrong type of motivation that's being chosen. Now, there are some environments where that lend themselves, although almost all motivational processes won't be sufficient. So I'm thinking about social economic deprivation, where the environment is so impactful that only the most extreme types of motivation will lead people to eat healthily and exercise, for example. So there are environmental impacts, but even in those extreme examples, motivation is still in the equation. It's just the environment is making most motivational systems redundant. So when people say I'm motivated, but then motivation is still part of the equation. And then the final thing, the misunderstanding, is you will see lots of people trying to ask what motivates. You will see it in the research world. You will see it in the general public world. What motivates? Okay, that is not a great question to ask, because the answer is anything and everything and nothing. Motivation, as the definition says, it's the internal forces, the internal systems at play. It's not the external contingencies. What's more appropriate is to say how motivation works. And I'll give you an example. Social support is often commonly proclaimed as a good motivator. But social support, it depends on whether that's as well. Social, going for a run with another person, as an example, so it's a better example. So people will think, oh, that's a good motivator. Well, it depends what motivational system that activates. If going with that person activates enjoyment and pleasure, which is one of the most fundamental motivational processes, then yes, going for a jog with another person will be successful in terms of motivation. But if you don't find that pleasurable, then it's the wrong motivational system. It's not going to motivate long-term behavior. So it's not the jogging with the person, it's what system are we activating that is the answer to motivation. So it's about rephrasing the question to how does motivation work? Because fortunately, we know a lot about how motivation works, and we can apply that to behavior change for physical activity and diet. So what motivates is probably not the best question. So with that in mind, I'm going to talk about how motivation works. And we're going to start off in a very abstract philosophical world, and then hopefully get to more sort of concrete tips. So indulge me for a slide or two. But who am I is one of the most important questions in motivation science, because your identity is one of the top gold standard motivators. Okay. So when I say sense of self, like I say, it's quite an abstract phenomenon. But if I were to say, okay, just give yourself some labels. Who are you? You know, you might say, I'm healthy, I'm a father, I'm happy. You know, it doesn't matter what those semantic labels are, but that gives you an idea of what I mean by your sense of self or your identity. Okay. Now, your identity, let's say, is one of the best types of motivation, because you don't really need any effort to express that identity. So what I mean by that is someone who thinks of themselves as an exerciser doesn't need much motivation to exercise. A healthy person doesn't need effort and motivation and willpower to eat healthily. Okay. Equally, someone who identifies by being healthy notices opportunities to be healthy. Okay, so our sense of identity really does drive most of our behaviors. Okay, so that's important to get in mind, because that's really not what we're talking about when we're talking about behavior change. Okay, when something is congruent with your identity, so let's say I think I'm a healthy person, eating healthily is congruent with my identity. Okay, that's a want-to behavior. Whereas if it's not so congruent with my identity, so I don't really see myself as a healthy person, then that becomes a should-do behavior. It requires effort. And that on the left, these should-do behaviors, that's what we're talking about when we're talking about behavior change. If behavior change concerned, if we're all working in congruence with our identity, then there wouldn't be any problems to solve. Okay, if everyone had a healthy identity, we wouldn't have a problem because they would be healthy. Okay, so all behavior change, trying to get people to be more healthy, to exercise more, concerns these should-do behaviors. They're not really congruent with a person's identity. Okay, and because we can identify these should-do behaviors, that's what we're talking about, behavior change, then that allows us to say, okay, well, we know a little bit about those types of behaviors. We can generate some principles that might be useful in behavior change. And so I'm going to go through a few of those principles now. And that's the abstract bit out of the way. The rest is concrete. But so I should give you some nice concrete tips to take home. Principle number one is minimize time between the intention and the planned behavior. Okay, we usually set an intention. Okay, I'm going to exercise today, for example, and then we hopefully enact that intention and go to the gym or exercise or go for a walk or whatever. Okay. The problem with that is, as I said, we're talking about the left-hand side here, should-do behaviors. Now, should-do behaviors require willpower, okay? And willpower is defined, self-control or willpower is the capacity to resist a temptation that is in conflict with a desired long-term goal. So our long-term goal, let's say, is to be healthy. And we are going to try and go for a walk in the evening to fit in with that goal of being healthy. And we need to resist temptation of our nice comfy sofa, for example. So willpower is the capacity to resist the sofa and go for that walk. Okay. These should-do behaviors require willpower, whereas when we're working within our identity, we don't need willpower. Okay. Now, one of the misconceptions is everyone thinks willpower is good and we need bucket loads of it. And the answer is probably not. It's not that. We don't need, we shouldn't need bucket loads of willpower. If we're using willpower to do whatever we want to do, if we're using willpower to go to the gym or go for a walk or run or eat healthily, then that's probably a bad sign. Excuse me, my slides are being a bit shaky. Willpower, it's nice to have, but if we're using it, it's a bad sign. And the reason that is because willpower, from a range of different perspectives, of different scientific disciplines, has been shown to decline over time. Okay, so I'll just very briefly go over a few. So, for example, if you're into evolutionary arguments, willpower is designed to break. It's designed to be fragile so that we can balance between different survival systems. Okay, so if we did the same thing all the time, we would eventually overexploit resources, and therefore we'd run out of resources. So we need temptation to do other things. Okay, so if you buy into the evolutionary arguments, that's one. Okay, so it's designed to be fragile, so we can't expect to then it be not robust, to be robust and not fragile now. Equally, if you look at diary studies, you will slip in your dietary habits more often in the afternoon and evening. So in other words, lapses in self-control are more prevalent as day progresses. If someone at 9:30 in the morning pushes a black forest gatto under your nose, then it's probably easier to resist compared to when someone does it at 4 in the afternoon. Equally, self-control requires effort. And so if you're continually using effort, that is going to deplete resources. And also self-control or willpower has a refractory period where if you use it once, you will want to use it less later. Okay. So these are all underlying explanations, but the overall argument there is your willpower declines over time, over the day, for example, or whatever. Okay. So that implies that the more time you have between your intention and your planned behavior, the more likely willpower will break. So the sooner that you can carry out the behavior following the setting of intention, the less likely you will have that your willpower will break. If you think about willpower as being really fragile, you need to try and avoid using it as a motivational system. okay? So you need to shrink the time between setting your intention, oh, I'm going to go for a walk later today, and when that point is, okay? That's the first principle. Equally, there's probably a less scientific, more logical reason why you should minimize the time between intention and planned behavior. This is Isaac Asimov. And if you're into science fiction, any of you, you will know he is one of the big three of science fiction authors, one of them being George C. Clarke, and I don't know the other one. But in one of his books, he eloquently put, in 10 hours a day, you have time to fall twice as far behind your commitments as in 5 hours a day. And that's quite a logical assumption. So the longer you have between your intention and doing your exercise, for example, the more that life gets in the way. So unanticipated consequences could be you actually have a horrible day at work, so therefore you don't feel like it, or it could be going back to Jackie from accounts who had these cakes earlier on. Now she's inviting us all out for drinks and so forth, so we're tempted to know that. So in other words, the longer the time between intention and behavior, the more opportunity for other temptations or obstacles to get in the way. So that's a second, more intuitive reason why you should shrink time. Time is bad for motivation. So the first principle was about time between intention and planned behavior. Time is bad for motivation in a second way, and it's principle number 2 is minimize time between behavior and outcome. And an outcome could be a benefit, reward, tangible, intangible, whatever it may be. Most people, when you think about exercise behavior in this study, when you ask people what are they going to focus on in terms of their motivation, they will say to you, or 68.75% will say, oh, I'm going to focus on health benefits or some sort of delayed reward. So exercise behavior, the most common delayed reward is health benefits. Whereas only a quarter will say some sort of immediate reward like enjoyment. Okay. So that's what people think motivates them, okay? These health benefits. That's not true. What actually happens is that immediate benefits are much, much more powerful. This is just an example study where they basically had 2 experimental groups and said, oh, we'd like you to do this exercise, and one experimental condition focused on an immediate outcome. We'd like you to focus on the enjoyment it gives you while you're doing your exercise. And the other experimental condition was a delayed outcome, i.e. health benefits. And what they did in terms of their outcome variable was how much they persisted with that exercise in terms of number of reps. And you found the ones who were doing it for enjoyment lasted much, much longer, well, not much, much longer, but more reps compared to the delayed outcome, which is particularly interesting for health benefits. It's quite rational and intuitive to say, oh, do this exercise because it's good for your health. The problem is those health benefits are such delayed that they don't transfer their properties to the behavior itself. And this is just one example of immediate versus delayed rewards. It's been done in reading, eating, different exercise contexts with different outcomes available. Immediate outcomes are much, much more motivating. Because what it does is the motivational power is in the outcome, the reward, the benefit. The motivational power is not in the behavior itself. So when you've got them too close together, the behavior and the outcome, the motivational power of the outcome gets associated with the behavior. Whereas if you've got a delayed outcome, the motivational power of that outcome doesn't get transferred to the behavior. So there's no motivational power behind the behavior itself. And it doesn't matter the size as well. So this is a reading task as well, as one of the many studies. So whether it was a small bonus of 50 cents on how much you read versus $1.50 per page, I think it was, it doesn't make any difference. So if you compare the white with the white and the grey with the grey, the effect is still there. The immediate bonus leads to more persistence at a task and more adherence to a task. Okay, so again, we see immediate bonuses irrespective of size. The effect still occurs. And then the last principle is not very good for certainly physical activity, is that effort is aversive. Effort has negative emotions attached to it. This is one of my favorite studies. It's a nice pictorial example, but B, it sounds like a fun study to do. When people pick cognitive effort, i.e. self-control or willpower we talked about, or it's an aversive experience. It's not a pleasant experience. And because of that unpleasant experience, it tends to be avoided if possible, okay? So this diagram here, this experiment was a choice, a simple choice between an NBAC cognitive task. NBAC is, broadly speaking, it's a bit like if I were to say, you have to remember the fourth last object. So that would be a fourth back. If I had sheep, dog, cat, cow, a four-back task would be what was the fourth from last object that I described. Three-back would be the third back, and so forth. So as you go up the x-axis, a four-back is more cognitively demanding than a three-back. Three-back is more than a two-back. So essentially, we've got cognitive effort on the y-axis. And on the x-axis, we've got the choice of receiving physical pain. So they had a choice between different types of different strengths of cognitive effort task, or they could receive pain in terms of a thermal prod on their arm. And just to give you an insight, 80 out of 100 pain level is the highest permissible ethically that you can ethically give to a human. So 80 is painful, 63 is pretty painful, and so forth. So you think, okay, I'd rather do a cognitive effort task or receive physical pain. In terms of the colours, if you look at the top left, for example, cognitively demanding task, we're into the yellows there. So most participants, over 75% of participants, would rather a moderately pain or a little painful prod than do cognitive effort. Even if we go to the top right, we're still talking 25-ish% of people would rather take the physical pain than the cognitive effort, okay? And that gives an overview of what cognitive effort feels like. Cognitive effort is bad, okay, motivationally speaking. People tend to avoid it. In terms of physical activity as well, we've got a double problem in that it doesn't matter if it's cognitive effort or physical effort, it's also aversive. It's not very nice. So this diagram is two different types of exercise. You've got one, the maximal treadmill test. And if you follow the line, we've got the affective valence there. So is it positive or negative? And the level of intensity or activation on the left-hand side there. And so if you see a maximal treadmill test, you'll see that it's fairly positive and low arousal. And as we get to the VT, the ventilatory threshold, so as the exercise becomes hard, it becomes a drastic shift to the activation becoming more intense, but also it feeling fairly negative, okay? There's a negative emotional label attached to that, okay? Whereas if we get a nice self-paced treadmill walk, we're fairly low levels of activation, and actually it remains positive and gets a little bit more positive, okay? So as physical effort becomes more intense, then the experience becomes negative. And if that aversion is very demotivating, so people want to avoid cognitive effort, And because of the aversion associated with physical effort, people will avoid that as well. Okay. So this aversion, this affective experience, is consistently associated with subsequent physical activity. In other words, if it feels good, if it is pleasurable, then people will want to do it again. If it doesn't feel very good, then they are unlikely to stay motivated and unlikely to adhere. And so that has implications for giving high intensity interval training to people who haven't experienced exercise and so forth. It may be very good for their physical health, but it's not very good for their adherence to motivation. So those are three principles then. Minimize the time between intentions and planned behavior, minimize time between behavior and the outcome, and effort is bad motivational, keep it low effort. So what are the implications? Well, the big implication for the first one is do whatever it is, whether it's physical activity. Physical activity is probably easiest to apply in that. Remember, we're talking about should-do behaviors. So people who experience exercise and physical activity as part of their identity, yes, you can do it whenever you like. For those who don't associate physical activity and exercise with their identity, and the implication of is do it as soon as you can. Okay, the longer time you have between, let's say, planning your day and the planned activity, the more time you give for obstacles to get in the way, and the more time you give willpower to break. Okay, so there are obvious complications to it in terms of the implementation. For example, shift night workers, people have children that they have to take to school, but that's an implementation problem. It's not a problem about the effect itself. So no doubt you'll have clients and patients who say, yes, but I have to do this, this, and this in the morning. Okay, well, how can we get it as soon as possible? Okay, can we do it before those tasks, or can we do it as soon as? So the idea is to try and get it done as soon as feasibly possible, I think. Principle 2 is a bit more an obvious one. Focus on immediate outcomes and benefits. So we saw that, like I said, there's a host of research that's shown that. One of the good things that I think try again. So yeah, make it require as little cognitive effort as possible. So going for a walk doesn't require a change of kit, for example. It doesn't require finding the kit out of the drawer and so forth. So making it your examples, the behavior that you're trying to change as low cognitive effort and as easy as possible. And also, if you're thinking about physical activity, that can be applied to the physical effort as well. So keep it low. Keep the goals in terms of physical activity very low, very easy, very pleasurable in the short term. And just to wrap it back up to the beginning, what those three things help us do, the aim is to keep people doing that behavior for as long as it becomes part of their identity. We have a natural tendency to make things that aren't part of our identity as part of our identity if we do it long enough. So if we can keep doing the behavior that we want to do, the physical activity or activity or whatever, long enough, then our brains will naturally incorporate it into identity over time. And once we've got that, we can then relax those rules and then do activity whenever we like, for example, and start making it a bit more complex and so forth. And I am going to finish it there before my internet cuts out again.
Brilliant. Thanks a lot for that, Ian. Shame we had a bit of a bad connection, but hopefully we can fast forward it when we watch it backwards. Please put any questions that you have in the chat. I think the first thing that springs out to me, Ian, you obviously described a lot of sort of theoretical sort of aspects of motivation. Is this sort of, or are those considerations kind of taken into account in sort of counselling and think about behaviour change for getting people to live healthier lives?
Yeah, one of the big it's interesting you asked hot topics to Emma, and I was thinking of what the hot topics are mine, and there's a real gap between sort of your geeky ivory tower motivational scientists who know quite a bit of motivation, and then the people who live in the real world, work in the sort of interventionists and behaviour change, I think, and the counsellors and so forth. And so there's a big gap there, I think. And so you mentioned specifically counselling. Counselling is often, in terms of, let's say, motivational interviewing for physical activity, for example, it takes quite a rational approach. And quite a lot of behaviour change interventions, they assume that these humans are rational, that if you give them the correct information, then they will make the right decision. And probably the hot topic at the minute within this field is trying to sort of bridge that gap between motivational science, which says that humans are not rational at all. They don't think logically. They think logically, but when it comes to the Black Forest Gatto under their nose, they're not rational at all, and so forth. So really bridging that gap between, the counselling and the interventionists to say, okay, let's adopt this almost like non-rational, irrational model.
Yeah, it's just nice to think through the practical elements of all of this. And I know, like Jack in Leicester, they do a lot of sort of long-term interventions now, and we've always got like behaviorists and psychologists on the team of these large grants. So yeah, it's just trying to make the connections.
Absolutely, yeah. I think there was a question on the chat there.
Yes.
Would this work with young children? It's interesting you said that, because I was listening to Emma's talk, thinking about the motivation and stuff. I would try and keep it a bit more simpler with children, in terms of, yes, the principles probably would work, but if you're doing these principles, I wonder whether you're overcomplicating, in that children actually, from a motivational perspective, are much better than adults. It's the children that should be teaching the adults about motivation. In terms of, children often do things just to learn, just to experience, and just to explore. And they are real optimal types of motivation. And it's only when us adults come along and give them prizes and tell them that life is hard and they need to compete and things like that, that they start using other types of motivation. So my answer is yes, I think they would work with young children. Certainly attaching the outcome to the behaviour and so forth is a good way of learning. But I wouldn't necessarily explicitly try and focus on these principles for young children. I would try and keep their optimal processes, exploration, enjoyment, fun, interest, as their primary motives. Hopefully Emma's saying, well done, Ian, you haven't told everyone to do the wrong thing with their feeding.
I think I just want to ask Emma another question, because she's hung around for an hour or so now. So I read quite a lot about sort of how, like, even preconception and in utero effects can affect children. So, like, do you know if there are any sort of risk factors or predictors of, in those earlier periods that can affect sort of like eating habits in children, whether it's fussy eating or even overconsumption?
Nice question, James. There's some really nice studies that have been done by some colleagues in France looking at what foods mothers consume during pregnancy, and there's evidence to suggest that if mothers eat, I think it's quite a lot of like carrots or green beans they tried it with, their babies subsequently have greater preference for those foods. as well. And the same thing applies via breast milk. So foods that are eaten by the mother while she's breastfeeding, those kind of preferences will kind of pass on. Again, it's about children getting different exposures to those tastes and the flavours via the mother, either in utero or via the breast milk, which I think is just fascinating. Humans are such clever, motivated individuals.
Yeah, it's a bit like, I think, sort of listening to music during pregnancy. It's almost as though the children then recognise those songs a bit better afterwards. It's incredible, really.
Yeah, absolutely. There's evidence for that as well. Music's not my specialism, but yes, children pick up their hearing develops before birth. So yeah, they can develop a love of the Spice Girls or whatever music it might be that you're playing to them.
Oh, brilliant. If anyone has any last minute questions, please pop them on the chat. If not, then because time's moving on, we'll call it a night. But clearly, I'm sure everybody will be happy to answer any questions if you send emails to our brilliant speakers this evening. Oh, we've just had one come in from Emma. It's for you, Ian.
Thanks, Emma. For educating patients with type 2 diabetes, how can you bring the enjoyment side into behaviour change when most changes are about health benefits? For example, switching white base. Food is a really tricky one, because when you talk about enjoyment, the reason why people eat cake is because it is really tasty and really, biochemical level, sort of more emotional level is enjoyment. So yeah, so my answer is I'm not sure. When you talk about things like wholemeal bread, what's the? I suppose you can take in some of Emma's stuff about child eating. Now, can you take something that is, okay, the wholemeal bread is not necessarily itself really enjoyable, but can you attach something that is? So, you know, I'm going completely a bit abstract, but getting, you know, a good friend to eat wholemeal bread with them, or doing it in a nice place. Okay, where's your favorite place to go for a walk? Okay, sit down on the park bench or whatever, and there do it. I'm stretching a little bit, but you can sometimes couple maybe a not so enjoyable behavior that you want, such as switching to wholemeal bread or carbohydrates. Sometimes you can attach it to something enjoyment, and then that enjoyment transfers to the behavior. So maybe something like that. But your example you give is one of the trickiest ones. That physical activity is a lot easier when you talk about enjoyment. But eating, actually, unhealthy foods are generally more enjoyable than healthy foods. So maybe focus on this attachment of something else that is enjoyable to maybe a wholemeal carbohydrate switch or something. But yeah, that would be my answer.
That makes sense. Thank you, Ian. I know it is tricky. Sorry for the question.
Yeah, no, it's good. Yeah, it's a good question.
More research to be done there, Ian, then.
Absolutely. How can we make wholemeal bread enjoyable?
There you go. That's a master's project. Cool. So if there's no more questions tonight, we'll leave it there. And I've just, like I was saying, if you do think of anything, please feel free to email Ian, Emma, or Jack, and you can get their email addresses off the website. So I guess we'll finish again by thanking Emma, Jack, and Ian for some great talks and contributing to the series. We do have another public lecture like this in 2 weeks' time, which will focus on hearing, which is something that's a little bit different. And that's given that we've got two relatively new colleagues in the school whose expertise relate to hearing. So hope to see some of you there in 2 weeks' time. But yeah, good evening, everybody. I hope to see you again soon.